झालं ना? डिस्प्लेवर आउटकम होऊन झालं त्याचं.
Ma'am, please start. Thank you.
नमस्कार. प्रत्येक व्यक्तीकडनं मग तो लहान असो का मोठा काहीतरी शिकण्यासारखं नक्कीच असतं आणि याच विश्वासाने मी सर्वांना गुरुपौर्णिमेचे शुभेच्छा पण देते आणि नमस्कार पण करते. गुड इव्हनिंग ऑल. वेलकम टू अनदर सेशन ऑफ थर्सडे थिंग्स. ऑन बिहाफ ऑफ MahaIP Women Committee, I welcome you all for this special session on type 1 diabetes. Pediatrics is growing very fast in all specialties, but general pediatrician remains the core of it. He or she needs to be updated from time to time regarding specialty topics, as he is the first contact of the patient trusts him, and another most important reason is the specialist may not be available at every place. Keeping this in mind, MahaIP Women Committee has planned this special session on type 1 diabetes with the experts like Dr. Renu Boralkar Madam and Dr. Ajinkya Patil. So to start the session, first of all, I welcome Dr. Sanjay Pakmode, President MahaIP, for his welcome address.
Namaskar. Good evening. Welcome to this Thursday Thrills, which is a unique program of Women's Wing. Very regularly we have done the Thursday Thrills, and in this Thursday also we have celebrated the few days of CIP also. So as Madam has wished, so let me wish all of you happy Guru Purnima. Each one of us is a Guru to each other in one form or the other in this journey of life where one keeps learning and gets supported. So wish you a very happy Guru Purnima. Now we got here the two. Let me welcome first our office bearers in absentia, Dr. Dynamic R. Amol Pawar, Secretary, our convener Dr. Sanjay Deshmukh, then Dr. Kashmiri Badbade from the Women's Wing, and Chairperson Dr. Jayaman, and all the CIP office bearers and the MahaIP office bearers and today's attendees. Now today's topic is diabetes. Now when we think of the diabetes, we think it is of an adult disease, but now in the recent times it is not such a case. Type 1 DM you might come across in some other form, the patient coming in the form of diabetic ketoacidosis, which needs a diagnosis, which is a diagnosis without touching the patient also. So if in the huge OPD we fail to diagnose DK, then we can face the lot of morbidity and mortality also. So which is very much treatable disease. So one should keep in the mind the diagnosis of type 1 diabetes. Now this particular diabetes incidence in the India is around 6 to 7 per 1 lakh, may get up to 10 per 1 lakh in the future times. So as already said, diabetes, India is a diabetic capital of the world. At the same time, we're getting so many patients of type 1 diabetes in our OPDs. Now, what is the problem between treating the children and the adults? This is an insulin-dependent diabetes. What we have found in our practice, there are a lot of patients leave the treatment in between when they feel all right. And sometimes they land in the diabetic ketoacidosis and then they come with the complications. Because in giving insulin on the regular basis, then for this you need, if middle class patient is concerned, you need a lot of fund also. No doubt there are the newer type of therapies are available in the form of the pumps. Still, maintaining the doses with the regular follow-up, lot of motivation is needed. At the same time, you need a peer support. At the same time, you need the approach to the competent healthcare professionals. So if we miss the diagnosis or if we undertreat the patient, they might get in trouble. So that's why the pediatrician comes in the picture. What is our duty? To get it diagnosed and to keep it under regular follow-up, manage the means tell him about the complications, monitor the complications, so that and at the proper time referral to the pediatric endocrinologist by taking their expert opinions. So I think today our speakers are going to highlight this session. Madam Renu Boralkar from Chhatrapati Sambhajinagar, 2 times EBCIP, very much experienced, and Dr. Ajinkya Patil from Jalgaon, a pediatric endocrinologist. So over to Jama.
Thank you, sir. Now I invite Dr. Amol Pawar to say a few words. Is he there?
No, ma'am.
I think he is yet to join. Till then, I call upon Dr. Sanjay Deshmukh, convener Maha-IP, for his address.
Good evening. Firstly, on behalf of Maha-IP, I wish you all the happy Guru Purnima to all the teachers and who taught us what we are practicing today. And Thursday still is efficiently led by our women committee, Dr. Jaya Shokar Madam, Dr. Kashmiri, and today we have Dr. Shushita Deshmukh also on this platform. And rightly said by our president, Dr. Pakmode, it's an alarming thing in India. As you know, obesity and juvenile diabetes are in hand to hand. And unfortunately, it is very much iceberg phenomena. And the most important thing is awareness. And today we have 2 speakers on Maha-IP platform, respected Dr. Renu Boralkar Madam from Chhatrapati Sambhajinagar and the young dynamic Dr. Ajinkya Patil from Jalgaon. So let's hear what they are doing in the management of juvenile diabetes. Welcome all.
Thank you. Thank you, sir. Now I would like to introduce our zonal member of Maha-IP Women Committee, Dr. Sushrita Deshmukh from Pune. She is a consultant pediatrician, KEM. She is running online PG clinic since 2024. She is a committee member of IIT Pune. She has special interest in vaccination, infectious disease, and PG education. I invite Dr. Sushrita Deshmukh as moderator for today's session, and she will take the session forward. Welcome, madam.
Thank you, Dr. Jaya Shivulkar, Madam, for giving me this opportunity to act as a moderator during this session. I will be taking the proceedings forward. So today's session we have, as Sir already said, we have on diabetes with a special application in the pediatric community. And we need to be aware of the acute emergencies as well as the regular OPD basis management of diabetes. And hence we have 2 stalwart experts here to tell us about that. So first, today's speaker is Dr. Renu Boralkar. Madam is a senior pediatrician and intensivist and ex-EBM National IIP member at Sambhajinagar. She will be talking upon type 1 diabetes mellitus and the most common complication being the diabetic ketoacidosis. So can somebody please play the slide? I will give a brief introduction about Dr. Renu Boralkar. Dr. Renu Boralkar, Madam, is MD Pediatrics and she's a gold medalist. She's HOD Pediatrics at St. Nandalal Duth Hospital, Aurangabad. She's a pediatric intensivist care, treating adolescent type 1 diabetes mellitus. Is a PG teacher to DNB as well as CPS DCH. And she's a central IIP. She was a central IIP member, executive board member in 23-24 and organizing joint secretary at the West Zone Pedicon in 2024. So without further ado, I would like to hand over the podium to Dr. Renu Boralkar, who will be talking about diabetic ketoacidosis, the most common complication in the pediatric population.
Namaskar Sagaryanna. Thank you so much for the kind introduction, madam. And as today is Guru Purnima, I will bow to all the gurus till today who has helped me to achieve the today's status of my life, whichever is the part. As a part, my mother and father, I bow to them, and also to all the gurus right from my childhood to the PGs, as well as now the IAP mentors, and today's all the faculties and the peers who have joined. And as a pediatrician, we are forever students, that I think, and learning always from our mentors, and most importantly from our own pediatric patients in our day-to-day pediatric practice. So I bow to all of you, and now I will share my slides without wasting any time. And also I would like to thank Mahaepi Women's Committee, Dr. Jaya Shivalkar Madam, Dr. Kashmiri and her team, and Mahaepi President Dr. Sanjay sir, as well as Dr. Amol, for giving the opportunity, and our convener Dr. Sanjay Deshmukh sir, and my co-speaker Dr. Ajinkya Patil. I also bow to him, as he has guided me for the last 8 days. I have asked him few of the queries. Though as a pediatric intensivist, I also need some support from him. So I asked him, and I am very much open to learning from anyone, even from the small child to adult or anyone. So I will share my slides here. Pallavi madam, are you seeing the slides? I will go in the, yeah.
Yes, yes, they are visible. Slide show वर करू टाक.
Oh, right. 1 minute.
Yes.
Yes, ma'am. It is
Okay.
full screen now.
Okay.
Kindly proceed.
1
Thank
minute.
you.
Yes, I will do it. So now the topic today is type 1 diabetes mellitus, and more commonly we will be going to speak here on the diabetic ketoacidosis, which is a complication of type 1 diabetes, and most of the time it is a decay in which we will diagnose the child as type 1 or the insulin dependent child. So it is the commonest chronic metabolic disease characterized by hyperglycemia as a cardinal biochemical feature. India is considered the diabetes capital of the world, as said by Dr. Sanjay Deshmukh and Pak Mode sir. Data from India reveals that a significant prevalence of type 1 diabetes, that is over 10 per 1 lakh population, with certain urban pockets reporting over more than 30 per 1 lakh population. Actually, as a EB member, I had tried to last 2 years when I was there to have a IAP registry of the type 1 diabetes children. We don't have the type 1 registry, so it is only the tip of icebergs that has been reported, and few of the NGOs which are which are supporting the type 1 children. We have also written to Government of India that they should do a type 1 clinics in all the government medical colleges and have a registry over there, so that we can have a type 1 children and the help to them for their further management, not only the TKA. So type 1 diabetes accounts for 5 to 10% of all the diabetes. So here we will see that there is type 1 and type 2 diabetes, where the typical age of type 1 is 10 to 12 years, usually in the adolescence period. It is usually diagnosed in the form of decay. It is insulin dependent, and obesity is uncommon in this age. Insulin resistance is uncommon, and the presence of beta cell antibodies is more than 90%, with also the C-peptide concentration will be undetectable or low, and optimal line of treatment, first line, is only insulin. So they are insulin dependent, and no child of type 1 should die of lack of insulin. That is what the government should be doing. And also we as a pediatrician should do. So when to suspect? Child may present as polyuria, polydipsia, nocturia, enuresis, loss of weight, vomiting, pain in abdomen, easy fatigability. These may not be diagnosed in the OPD sometime. The children may go from one clinic to another, and once in a time they may be diagnosed, or they may present in a decay. So epidemiology is incidence is 4.6 to 8% per 1,000 person years among the people with diabetes. 10% of known type 1 diabetic patients in developed countries, and 35 to 40% in developing countries are seen. Decay at the time of first diagnosis of diabetes mellitus in children is reportedly 30%, but it is very high in developing countries. We don't have the data at present to the mark. So diabetic ketoacidosis is the end result of the metabolic abnormalities resulting from severe deficiency of the insulin or insulin ineffectiveness associated with increase in counter-regulatory hormones. Most common cause of diabetes related death in children is decay. Decay occurs in 20 to 40% of new onset diabetes children. Also, with known diabetes children who omit the insulin doses, who do not successfully manage an intercurrent illness, and also most commonly is that they may be doing the other pathies. So the decay is having mainly the insulin deficiency, which is an anabolic hormone, and there is an increase in the counter-regulatory hormones, the catabolic hormones, that leads to the hyperglycemia. So this is a pathophysiology. In short, we will see it is absolute insulin deficiency or stress, infection, or insufficient insulins, and the counter-regulatory hormones are on the rise. And then there will be hyperglycemia, with leading to the various type of presentation like dehydration, acidosis. So biochemical criteria for the diagnosis of DKA is hyperglycemia, where the blood glucose more than 11 millimoles per liter or 200 milligram per deciliter. The ketonemia, usually the blood beta hydroxybutyrate more than 3 millimoles per liter or moderate to large ketonuria. And the venous pH is less than 7.3, or the serum bicarb is less than 18 millimoles per liter. This is the recent update by ISPAD, where previously the serum bicarb was less than 15. Now it has come to less than 18. So the classification of DKA is mild, moderate, and severe according to the CO2 levels, the pH, and the clinical. Most importantly, the severe form, where you can see the CO2 less than 10 in the ABGs, the pH is less than 7.15, and there is a clinically small, or we know that the breathing, which is their hunger breathing, or the depressed respirations, and sleepy to depressed sensorium to the coma. Risk factors for decay in newly diagnosed patients: it can be a younger age presentation, delayed diagnosis, lower socioeconomic strata, and residence in a country with a low prevalence of type 1 diabetes. The risk factors for decay in newly diagnosed, we have seen. Now, the risk factors for decay in known diabetes will be the omission of insulin for various reasons. It can be that it will be a denial phase for the initial time, that the parents don't accept. They will go to the other pathies. They will say, why my child is only affecting? There will be no diabetes in children. We have never heard diabetes in children. And so they omit the insulin. There is limited access to the medical services, especially in the rural areas. An unrecognized interruption of the insulin delivery in the patients with insulin pump, insulin delivery in the patient using an insulin pump. So these are the reasons. So what are the signs and symptoms which are commonly seen? Polyuria, polydipsia, dehydration, weight loss, lethargy, nausea, vomiting, abdominal pain, commonest presentations with fever. Then it is the acetone smell breathing, or the fruity odor which is there in the small breathing, flush faces, confusion, delirium, hyperventilation, tachypnea, tachycardia. So pathogenesis lies of decay, that is the main is dehydration, dyselectrolytemia, and the cerebral edema. So dehydration, it is usually because of the hyperglycemia, increased urinary output, and electrolyte losses. Excretion of ketone anions also contribute to the osmotic diuresis, insulin deficiency. Acidosis can also cause the nausea and vomiting, leading to dehydration, insensible fluid loss through small respiration. So dyselectrolytemia, the hypokalemia, most commonest form of dyselectrolytemia. It is because of the hypertonicity, acidosis, glycogenolysis, proteolysis by counter-regulatory hormones, osmotic diuresis, and vomiting leads to the hypokalemia, and the hyponatremia with the hyperglycemia. So initial investigations of decay is the blood glucose, and also the fasting blood sugars, urea, electrolytes. Electrolyte on the blood gas machine give a guide until the accurate results are available. CRP if there is an underlying infection, blood gases, venous or capillary, ketones. Near the patient, the blood ketones, beta hydroxybutyrate whenever they are available, or the urinary ketones can be done. If sufficient blood sample for the new diagnosis investigation, we can also later on do the HbA1c, TFT, SELECT screen, as it is a multifactorial autoimmune disease, as we know. And other investigations can be done if indicated whenever, like chest X-ray, then the CSF, blood cultures, urine analysis, etc. Full clinical assessment has to be done initially when the patient comes to you with the conscious level assessment in the institute, hourly neurological observations, including the Glasgow coma score, and also whether or not the drowsy on admission. Full examination looking particularly for the evidence of cerebral edema, which is the most commonest complication of DKA. So we can have the further slides on the cerebral edema, and there can be infection. You can watch for the ileus, which is common in DKA. Weigh the child if possible. Use the most recent clinical weight if available, or estimated weight from the centile charts. So differential diagnosis of DKA is hyperglycemic hyperosmolar state, which is can be confused with DKA. Starvation causing ketosis is not associated with acidosis, and blood glucose levels are normal or low. And a high anion gap, metabolic acidosis, including lactic acidosis, ingestion of salicylate, ethylene glycol, paraldehyde, and acute kidney injury or the CKD. So yeah, ICU admission will be required usually in the age less than 2 years of age, and with a moderate to severe decay, suspected cerebral edema, which is an emergency. So management, the goals of the treatment is that the correction of the dehydration or the shock if present, acidosis, hypoglycemia, hyperglycemia, hypokalemia, hyperosmolality, risk of cerebral edema if there, treatment of precipitating infections associated. And so the lifesavers for the DK treatment, first is the IV fluid and IV fluid. Insulin comes later and potassium go hand in hand. So IV fluids that we will be seeing a dehydration. So requirement will be deficit plus the whatever is the maintenance is there, and determine if the patient is dehydrated or shocked. Calculation has to be done for 48 hours. Based on the degree of the DK, deficit fluid will be calculated. 5% deficit dehydration will be there for moderate decay, and 10% for severe decay. Usually we does that. For the first hour, we usually give 10 ml per kg of the 0.9% normal saline bolus over 1 hour, which is a resuscitative fluid. From the second hour to the 23rd hour, we will calculate the fluid requirement in the form of the deficit fluid, which is 10% plus the maintenance fluid by the Holiday-Seeger formula. We have to minus the bolus which we have given initially upon the 23 hours. So it is the NS that we'll be starting with. Assuming that the 10% fluid and the young people are there, we will start it accordingly. Next 24 hours, that is the next, after the first 24 hours, the next 24 hours, it will be the deficit fluid plus the maintenance fluid. Upon the 24 hours, that we will be calculate the drip rate. So it can be either half normal saline plus D5 or half normal saline plus D10, because the sugars will fall below 300, and at that time we have to change the fluids, or we can change according to what the child can take orally if acceptable. So acidosis, it is the fluid replacement and the insulin therapy that effectively corrects the acidosis. No need for bicarbonate administration. I am emphasizing all this at the same time, but the lack of resolution, exceptions are there. Lack of resolution of acidosis is most frequently due to the development of hyperchloremic acidosis, where we are giving more NaCl fluids. This is generally a benign condition, should not delay the transition to subcutaneous insulin. Rare causes of persistent acidosis include insufficient fluid administration, infections, sepsis, and incorrect preparation of the intravenous insulin preparation or insulin. So next line is that we will be giving the insulin. Start an insulin infusion only 1 to 2 hours after beginning the intravenous fluid therapy. Use prefilled syringes. Usually these are not available in India. We usually do a prefilled syringes where in the form of add 50 units of soluble insulin actrapid, for example, to 49.5 ml of 0.9% sodium chloride. Insulin rates should start at 0.05 units per kg per hour, and 0.1 unit per kg per hour usually are suggested, and you have to just titrate with the respective whatever glucose levels are there in the next 1 hour, 2 hour, 3 hours. As the IV insulin bolus should not be used at the start of the therapy, never give a IV insulin bolus, as it can precipitate shock by rapidly decreasing the osmotic pressure and can exacerbate the hypokalemia. So potassium replacement, DKA patients suffer total body potassium deficit on the order of 3 to 6 millimoles per kg. Major loss of potassium is from the intracellular pool. Ensure that all the fluids except the initial bolus, we will give the 40 milliequivalent per liter, that is 20 milliequivalent per 500 ml. We have to give the KCl 20 milliequivalents or 40 milliequivalents per liter unless there is evidence of renal failure. So start replacing potassium after the initial volume expansion and concurrent with the starting of the insulin therapy. It is recommended that potassium is only added to the IV fluids after the patient has passed urine. It means that patient is not in renal failure, that we all know. Bicarbs, do not give intravenous soda bicarb to children and young patients with DKA. Only consider bicarb if there is a life-threatening hyperkalemia in severe acidosis with impaired myocardial contractility. Also here we can consider that if it is not responding, then we can calculate the anion gap and also the corrected sodium. Phosphate and hypophosphatemia. Phosphates are lost during decay due to the osmotic diuresis, and serum phosphate is often low in the recovery phase of severe decay. So supplements or replacements, for example, potassium acid phosphate, are not required unless there is severe hypophosphatemia, which is associated with metabolic encephalopathy, reduced myocardial contractility, myopathy, dysphagia, or ileus. Clinicians should be aware that the admissions of phosphate can precipitate hypocalcemia. So here the other thing is hyponatremia. Is it really a hyponatremia? It is pseudo-hyponatremia in the initial stages. So serum sodium is wasted during the diuresis. Calculate the corrected sodium accounting for the degree of hyperglycemia and hypertriglyceridemia if it is known. If true hyponatremia is present, it is generally treated with NS. The formula for glucose in milligram per deciliter for the corrected sodium is measured sodium plus 1.6 into sodium in milligram per deciliter minus 100 upon 100. Now, most important thing, what after this giving the initial IV fluids, after the 1 hour of the IV fluids, the starting of the insulin and the potassium, the clinical and biochemical monitoring is needed. 1 hourly we should monitor for the vital signs, for the neurological assessment, for amount of the administered insulin by the blood glucose estimation, accurate fluid input, including all the oral fluid and output, and capillary blood glucose concentration. And every 2 to 4 hourly, we should also be watchful for the serum electrolytes, blood urea nitrogen, calcium, magnesium, phosphate, and blood gases if possible, and blood beta hydroxy butyrate concentration, as it will detect the end of the ketoacidosis wherever it is possible. So tips for managing the DKA PICU, you have to have a 2 large bore intravenous lines if possible, frequent lab monitoring, hourly neurochecks, watch for falling sodium, correct the hypokalemia aggressively, never give bicarbonates, do not titrate insulin drip, mannitol to the bedside whenever there is possibility of the cerebral edema, order IV fluids pre-PICU arrival. You can tell the patient, PICU people that there is a child possibly in the DKA, so you have to have that IV fluids in the prepared. So search for the underlying causes, especially in the known case of the type 1 patients, like having an infection or non-compliance. So the complications, most commonly cerebral edema of decay, were most feared and frequently life-threatening complication leading to the death. Hypokalemia, hypoglycemia, associated septic shock, cerebral hemorrhage, or thrombosis. Decay is a prothrombotic stage. So cerebral edema complicating decay remains the major cause of morbidity and mortality in children and adolescents with type 1 diabetes. Clinically significant edema, cerebral edema usually develops within the first 12 hours after the treatment has started. Signs and symptoms may be headache, change in the neurological status, which was normal previously, specific neurological signs, decrease O2 saturation, Cushing's stat, as we know. And the risk factors for cerebral edema is younger age, new onset diabetes, longer duration of symptoms, greater hypocapnia at presentation, increased serum nitrogen, urea nitrogen at presentation, more severe acidosis at presentation, and backup treatment for the correction of acidosis if given in the first hour of the management, a marked early decrease in serum effective osmolality, greater volumes of fluid given in the first 4 hours, administration of the insulin in the first hour of fluid treatment. So please mind that you have to avoid these things to prevent the cerebral edema as a complication. So treatment lies in the adjustment of the fluid administration as needed to maintain the normal blood pressure while avoiding excessive fluid administration. Elevate the head of the bed at 30 degrees. Mannitol, as we know, 0.5 to 1 gram per kg IV over 10 to 15 minutes. Hypertonic saline, 3%, 2.5 to 5 ml per kg over 10 to 15 minutes. Mechanical ventilation may be necessary for patients with impending respiratory failure due to severe neurologic compromise. So these are certain charts which is given in Nelson. As we know that we have seen the clinical history, the clinical signs, the diagnosis is confirmed, biochemical features and investigations we know. So that later on, if it is a shocked patient, then resuscitate according to the PALS guidelines. And then if it is not a shocked patient, then you go according to what we have discussed with the initial IV fluid therapy with the normal saline for the 48 hours management therapy, and later on with the insulin addition in the next 1 hour. And also if therapy start with the subcutaneous insulin, continue with oral hydration as the patient improves. And this is the clinical observations that we will be needing, that is every 2 to 4 hourly. And acidosis, if not improving, reevaluate and see for any other underlying causes like anion gap, hyperchloremic acidosis, and also the warning signs for neurological deterioration for the indication of cerebral edema and the management as we have discussed. Do not stop the insulin infusion while the glucose is being infused, as insulin is required to switch off the ketone production. If the blood glucose fall below 6 millimoles per liter, increase the glucose concentration of the IV fluids. That is, we can add the half normal saline plus D5 or half normal saline plus D10. If there is a persistent ketosis, continue to give the insulin at the dose of 0.05 units per kg per hour. If the blood glucose fall below 4 millimoles per liter, give the bolus of 2 ml per kg of 10% glucose and increase the glucose concentration of the infusions. So introduction of the oral fluids and the transition. The oral fluid should be introduced only when substantial clinical improvement has occurred. That is, mild acidosis, ketosis may still be present at that time. Persistent ketonuria characteristically occur for several hours after serum beta hydroxybutyrate levels have returned. So we pediatricians should not run after urinary ketones. It is the serum beta hydroxy levels which determines that the ketosis has disappeared, and not the urinary ketones. Urinary ketones will be present for the next 48 to 72 hours in the urine. Decreasing the insulin infusion rate should be considered once the ketoacidosis has resolved. And also, the insulin infusion can be discontinued when the child is alert, metabolically stable, when the blood sugars have gone down below 200 milligram per deciliter, pH has improved to more than 7.3, bicarbs are more than 18 millimoles per liter. And the most convenient time to change to subcutaneous insulin is just before the meal time. So insulin management, once the ketoacidosis has resolved, this is the most challenging in the ICUs when you are when you want to shift the patient in the ward, you have to be very much alert. So to prevent the rebound hyperglycemia, the first subcutaneous injection of insulin should be given 15 to 30 minutes with the rapid acting insulin before stopping the insulin infusion drip to allow sufficient time for the insulin to be absorbed. With long-acting insulin, the overlap should be longer and the rate of the IV insulin administration gradually decreased. For example, for the children on a basal bolus insulin regime who are already diagnosed with a DK type 1 and now landed in a DK, the first dose of basal insulin has to be administered in the evening and the IV insulin infusion is stopped in the next morning. After transitioning to the subcutaneous insulin, frequent glucose monitoring is required to avoid the marked hypoglycemia episodes. So continuing the management, the treatment has to be continued in the form of insulin therapy. The guidelines are there where the children with the first diagnosis where no insulin reserves are there, you have to have a zero point 0.7 units per kg per day prepubertal, 1 unit per kg per day at mid-puberty, and 1.2 units per kg per day by the end of the puberty as per the ISPAD guidelines. Children with type 1 diabetes should be treated with multiple daily injections of prandial and basal insulin, or they can be having a continuous subcutaneous insulin infusions in the form of insulin pumps whenever the child can afford or the parents can afford. Most children with type 1 diabetes should use rapid acting insulin analogs to reduce the hyperglycemia. Home monitoring is very, very important as a basic education. So what happens most of the time, many of the PICUs or the pediatricians where they manage the pediatric decay, they have a very rapid thing to change the patient to some of the insulin therapy on their own, or they refer to some NGOs which are available, or the pediatric endocrinologists where they are available. But this should not be done, because this is the time where the gray zone is there and the patient can land in either a hypo or a hyperglycemic states. And so the home glucose monitoring has to be explained in the whenever the patient is in the inpatient department by the treating pediatrician, with the glucometer use and also the ketone strips, urine strips which are there. Insulin injections should be explained, how it is to be given, the types of the insulin, the sites, or also they have to be explained to the parents. The meal planning by the dietitian, the exercise related issues of the insulin, about the symptoms of hypo or hyperglycemia, they have to be explained to the child if he's in the adolescence, or the parents if the child is in the lower age group. And also the importance of the subcutaneous management, that is the management of the subcutaneous insulin management. So, or the continuous insulin management. So the impact of poor control of diabetes mellitus should also be explained to them, as we know that many patients, parents are in the denial phase. They go to the other pathies and they might land further in the complications and again in decay, or they might have certain other complications of the kidneys or like that. So sick day care has to be explained very rigorously to the parents, and 24/7 helpline numbers has to be given. But a routine PICU pediatrician, usually we don't have, every hospital don't have the that is the daycare management. So we have to refer to the proper doctors who are either a pediatric endocrinologist or those NGOs where they are taking care by the pediatricians, where the daycare management or the ambulatory management will be taken care of the patients. The next talk will be on the same by Dr. Ajinkya Patil. So basal insulin, mealtime insulin, and correction insulin is what which is required. And insulin replacement regimes typically consist of NPH insulin, long-acting analogs, and continuous delivery of rapid-acting insulin via an insulin pump if possible. Basal insulin analogs have long duration of action with flatter, more constant plasma concentrations and activity profiles than the NPH. Rapid-acting analogs, that is RAA, have a quicker onset and a peak and shorter duration of action than the regular human insulin. In the children with type 1, treatment with analog insulins is associated with less hypoglycemia and weight gain, as well as a lower HbA1c compared with the human insulins. A case scenario, we will see a 10-year boy with vomiting, small breathing, glucose 490 milligram per deciliter, pH is 7.08, ketones is 5.2 millimoles. So he is in a severe DKA. Weight is 24 kg. So we will see how we'll have the year only. I will be sharing the IV fluid guidelines. If the weight is 24 kg of the boy, for the first hour, the 10 ml per kg of the NS bolus for the 1 hour, which is 240 ml, can be given over 1 hour. From the second hour till 23rd hour, we calculate is the deficit fluid, which is 10%, plus the maintenance fluid according to the Holliger-Seeger formula, minus the bolus upon 23. So here is the 24 kg weight. So 100 ml per kg, it is 2400 ml plus 1580 is the maintenance fluid. We have to minus the 240 ml, which the bolus we have given in the initial period, divided by 23, which will be coming as 162 ml per hour. And after, at this level, we will be adding the potassium as per the 40 milliequivalents per liter of potassium chloride and the insulin drip in 0.1 unit per kg per hour at this level. And later on, after the next 24 hours, the fluid will be the deficit plus maintenance upon the 24 hours, which is 166 ml per hour. So that will be that is the example how we give the IV fluid for the DKA. So fluid change has to be done when the sugar is more than 300, we use NS. When it is less than 300, 250 to 300, you use the N2, that is half NS plus D5. And less than 120, 150, we use the half NS with the D10. And there is calculations, we can get it from the net. So take home message, while the inpatients mortality rates for the DK are generally very low if managed properly, recent analysis conducted in India reported that up to 30% of hospitalized DK results in inpatient death because of the improper management. Among all the type 1 diabetes related deaths for the patient aged less than 30 years, 54 to 76% can be attributed to DKA. Remember, DKA means fluid therapy, potassium, insulin, the mainstay of the treatment. So in short, we will be seeing what is DKA versus hyperglycemic hyperosmolar state. So here it is that the urinary ketones are more in DKA while no in HHS. The next thing is that the osmolality is more than 315 in HHS. You are never too young to have diabetes. Remember this. Children of any age can develop the diabetes. These are my references. And I would like to highlight here that I am associated with the NGO UDANKids.org is the website, and it is the UDAN organization which empowers the children with type 1 diabetes. More than 1500 kids are currently undergoing treatment from Marathwada region and around it, surrounding it. And it is managed by Dr. Archana Sarda, who is the adult diabetologist. She had a passion for pediatric diabetes, where she developed this UDAN organization 25 years back for the type 1 diabetes, where no one was there to take care in Chhatrapati Sambhaji Nagar or Marathwada. And I have been associated with this organization UDAN for last 15 years. So we have this, after the TK, the parents are very much confused. How should I treat my child? How should I give the food? How should I give a insulin to a child less than 5 years? How can he take the food on the time? So these are very, very small things that we have to take care. No one can explain to them on our pediatric basis. So these are the kits which are available for the emergency management. We tell them at the home. This is the carb counting which we can do. We ask them to do. This is the continuous CGMS, that is the monitoring we usually give to the children who can possibly afford it. And also this is the group of type 1. These are the adolescents group which has climbed for the mountain Kalsubai last year. We had gone over there, and two of the kids had gone in hypo also there. We managed at that altitude. And Dr. Archana is very passionate about her children a day-to-day basis with her. So these are the type 1 diabetic champions where we still give them the learning. There are 17 to 18 mothers who are educators, who themselves have been given the type 1 educator. There is type 1 mom diabetic program which is there. Here the children are being told to how to take the insulin, how to manage their day-to-day activities. And also UDAN's kids.org. Please do visit them. It is empowering children with type 1 diabetes, and we create a setting. And also currently we have gone for a TARA, which is that treating the kids of type 1 at the rural area with minimal resources. Thank you so much for patient listening. I will stop sharing.
Yes, so thank you, Dr. Renu Borarkar, for delivering such a power-packed talk in such a small time span on diabetic ketoacidosis in children. And a few take-homes which I realized from that is that high index of suspicion must be kept for type 1 diabetes mellitus patients with DK when the child presents with dehydration or in an altered or comatose state. DK should be thought of. And most common causes could be omission of insulin, or when the child is extremely sick, or bad access, poor access to healthcare facility. One more thing I realized is the basic things should be followed, which is A, B, C, D, E, airway, breathing, circulation at first, and dehydration for correction of shock is of prime importance. Later on, insulin and potassium should be added. Soda bicarb, like you said, should not be added because simply fluid correction as well as insulin will correct the acidosis. And one more point I liked was insulin drip should be stopped about 12 hours after you start the child on subcutaneous insulin. So thank you very much for this wonderful talk. I would like to take a few questions which were mentioned in the chat box.
Okay.
So I have Dr. Rajesh Kulkarni here, who says that rapid excessive fluid correction can also be one of the causes of cerebral edema. So
Right.
yes, so your comment on that is absolutely right, right?
Yeah, right. I had mentioned in my slides also.
Yes, and
Yeah.
he asks one more question is what is the role of long-acting insulin, glargine, which we normally use as a basal bolus? What is the role of glargine in decay?
It is not in the decay. It is, I had said that if the patients are already diagnosed with type 1 diabetes landing in decay, if they are now to be converted into the routine management, we have to start the basal insulin, that is the glargine, in the 12 hours before we are stopping the insulin trip. I am not telling that decay manage should, yeah.
No, madam. I think he wants to ask whether glargine has a role in the management of acute decay.
No, acute decay doesn't have, it is only that already diagnosed type 1 landing in a decay, they have to be first started on the routine dose of the basal, that is the glargine, and then after 12 hours, the insulin drip has to be stopped. Not the first timers.
Okay, thank you.
Okay.
And I have one more question in the chat box.
Right.
It says whether fluid should the entire fluid which we calculate, the deficit plus the maintenance, should it not exceed 1.5 to 2 times the maintenance?
Right. That is what the SPAD guidelines says. So that is correct thing, whatever the our delegate has mentioned. Yeah.
Okay, thank you so much. And I saw Dr. Devendra Sarin in the people attending here. So, sir, I would ask you to whether some expert comments on the issue here.
Yes, excellent presentation, Dr. Renu. Covered
you, sir.
every aspect very nicely, very precisely. It was a very crispy presentation. Congratulations.
Thank you,
Great
sir.
going.
Thank you so much. Thank you.
So we move to the presentation for the next presentation, which will be delivered by Dr. Ajinkya Patil, and he will guide us onto the ambulatory management of or home care based management of the diabetic type 1 diabetes mellitus patients in our OPDs. Dr. Ajinkya Patil has done MD pediatrics and he's a pediatric and adolescent endocrinologist. He is consultant pediatric endocrinologist at Homocare Pediatric and Adolescent Endocrine Clinic, Jalgaon. He's an assistant professor in the Department of Pediatrics at Dr. Ullas Patil Medical College at Jalgaon. And he's an author of one chapter in pediatric endocrinology textbook and numerous original articles in index journals. He's visiting consultant at many places like Orbit Hospital, Chirantan Hospital, Dhule, and RT Hospital, Nandurbar. So handing over to Ajinkya Patil for his talk here.
Thank you so much, ma'am. And I want to thank the MahaIP Women's Committee and MahaIP platform for giving me this opportunity on the day of Guru Purnima to learn from such stalwarts. And I'll just add a few things which I have learned in my short experience. Should I share the screen? Is my screen visible, ma'am?
Yes.
Yes, sir.
Yes,
Yes, very
Yes, please.
clearly.
Yes, please.
Thank you so much, ma'am. And I would like to ask for blessing for from all the seniors and all the teachers who have guided me throughout this journey, and all the teachers who are still going to guide me through this journey ahead. So happy Guru Purnima to all. Today's topic is ambulatory care in type 1 diabetes. Now, as time goes and as we see multiple patients, I think we can agree that every day we learn something new about ambulatory care in type 1 diabetes. From patient experiences to understanding their cultural problems, we try to find out solutions to different situations. And I'm going to just go through a few slides and emphasize on what we need to do and what we need not miss at all. So just following up on what Renu Gorakar madam very beautifully explained, there are certain don'ts in DK that we should remember no matter what. Don't give bolus rapidly at all. First, give it slowly over 1 hour and then start insulin infusion after the bolus itself. But very important, I have highlighted this in red. Do not forget to prime the tubings with insulin before starting the insulin infusion, because this insulin tends to stick to the plastic tubings. And if you do not give it, or if you do not prime it, then eventually most of the insulin that you're going to try to give through infusion is going to stick to the plastic tubings after all. Now, of course, as ma'am very beautifully explained, do not use soda bicarb unless there is impending cardiorespiratory collapse or the pH is below 6.9. And again, do not use urine ketones to check for resolution of DK. So this being said, I think it is very important to discuss the burden of type 1 diabetes worldwide and in India as well. So currently, there are about 9.5 million people worldwide who are living with type 1 diabetes. And as we speak, for every 1 lakh children, there are about 5 to 15 children newly diagnosed with type 1 diabetes. Now, India currently is home to about 9,90,000 people who are living with type 1 diabetes. And as per the latest IDF 24 data, India International Diabetes Federation, India ranks second in the number of people of all the ages who are living with type 1 diabetes, and ranks first in children below 20 years of age who are living with type 1 diabetes with a number of 3,01,000, which is now gone up to almost 3,50,000 over the 1 year. So when should you suspect type 1 diabetes? Very clearly, it has been explained: polyuria, polydipsia, nocturnal enuresis. But very clearly, you have to ask for objective reasoning and objective answers. So when the child who was initially not, drinking water for within 2 to 3 hours, now started drinking water almost every 5 minutes to 10 minutes, or has started asking for bathroom breaks in the school every 5-10 minutes, or has been getting up during the middle of the night to pass urine and drink water as well. This is something that is objective and that tells us that the child particularly has polyuria or polydipsia. Then basically in DK, the sugar that is getting assimilated and gets mixed in the blood is not being able to get transported to various organs to provide energy because insulin is not present. So the child tends to eat a lot, and despite that, there is failure to gain weight or significant weight loss over a significant period of time. Then any child who comes with complaints of persistent glycosuria. So clinically, how do you ask for this? Many parents would come and complain that whenever he passes urine, there's a bleaching or spot appears around the urine pot, or there are ants which are moving around the urine pot. That usually tells us that possibly the child is passing urine which is glycosuric. Then any child who presents with candidal vaginitis or balanitis or multiple recurrent skin infections should be strongly suspected to have diabetes and should be worked off. And of course, when there is a classical triad of acidotic breathing, vomiting, abdominal pain, these are the classical symptoms of DK which should suspect or which should warrant evaluation immediately. So what are the types of diabetes in children? Even if below 20 years of age, the most common presentation is type 1 diabetes, which should be wary. And over the last 5-10 years, we've seen there is an alarming rise in the rates of obesity and metabolic syndrome. So we've started seeing a great deal of patients coming in with type 2 diabetes before the age of 20 years. So always keep that suspicion in mind. Of course, there are other minor categories which consist of monogenic causes, syndromic causes, and secondary causes. So from a clinical point of view, and type 1 diabetes, I would say, is more of a clinical diagnosis than any biochemical diagnosis. So to differentiate between type 1 and type 2, usually type 2 children have a obese phenotype. They have acanthosis, that is a blackish or darkish pigmentation of the nape of the neck, armpits. If you work them up, they may have high C-peptide levels, and antibodies which are associated with type 1 diabetes may turn out to be negative. However, some of them may still harbor type 1 diabetes antibodies. Now, about C-peptide, there's a caveat when we are measuring C-peptide in such children. In the initial phase of glucotoxicity, C-peptide high may still be low or undetectable in children with type 2 diabetes. So we have to be wary of that. And of course, when there is a strong family history of type 2 diabetes in the family, with an obese child, we must think of type 2 diabetes. Then type 1 obviously has a lean phenotype. Usually when measured, the C-peptide levels are low or undetectable, and antibodies in most cases, about 90% of cases, are positive, and about 10% of cases of type 1 diabetes are idiopathic. So their antibodies are negative. Now we have to look out for such certain cases of monogenic diabetes. So any child presenting with onset or diagnosis of diabetes below the age of 6 months should be thought of and should be suspected to have neonatal diabetes mellitus. Now, in such children, why is making a diagnosis very important? Because some children may be responsive to sulfonylureas, and they may benefit from just oral treatment. Now, usually such children may come out with some extra pancreatic features like hepatosplenomegaly or intractable diarrheas. And usually, if there is a strong family history or 3-generational history, we have to think of causes like maturity onset diabetes of young, so MODY. There may be some syndromic associations with type 1 diabetes. Very commonly or very popularly, we know DID mode syndrome, that is the Wolfram syndrome, which comes with an associated diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Then some obesity syndromes like Alström syndrome or Bardet-Biedl syndromes may present with type 2 diabetes or diabetes. And then there is a relatively rare but an interesting cause of syndromic diabetes, which is thiamine responsive megaloblastic anemia or Rogers syndrome. Now, for this, only insulin is not available, is not the only course of treatment, but they also require thiamine supplements. Then there are some mitochondrial causes and lipodystrophy syndromes, which can be associated with type 1 diabetes. There can be some secondary causes. So steroids, secondary to chemotherapy, or thalassemias, or cystic fibrosis related diabetes. These are important causes which we should consider in children who are undergoing some chronic therapy. So as ma'am also discussed in the last talk, when a child is diagnosed newly, the parents are usually very disparaged and very troubled during this time. They keep wondering what type of diabetes they have, why they have only been chosen to have diabetes. If they constantly ask you questions like if it is lifelong or not, if it can be cured, or if the child can receive oral drugs instead of insulin. There are many multitude of questions which you have to answer. So I think when we are managing diabetes, just like in a case of stroke or some cardiorespiratory collapse, we say that it is important to manage during the first golden hour. It is important to manage type 1 diabetes during the first golden month of management. And what is important and what is needed? You sit with the child, you sit with the parents, give about 1 or 2 hours and sit with a pen and paper, explain to them the pathophysiology, why it has happened. Tell them type 1 diabetes is not type 2 diabetes, or it is not similar to the diabetes that some of their elder members in the family might have. Then you have to burst myths about type 1 diabetes. Very commonly parents keep on asking us कि अभी 18 साल से छोटा है, बड़ा होने के बाद शायद वो type 2 हो जाएगा, जिसको oral medications मिल जाएंगे और उसको काम चलेगा. So you have to bust such myths about type 1 diabetes. Always and always our emphasis should be on insulin, insulin, and insulin. It is the cornerstone of type 1 diabetes, cornerstone of management of type 1 diabetes. Now, usually children with type 1 diabetes who have been diagnosed newly have a phase of partial remission or partial recovery. Now, what happens is usually 1 month post diagnosis, and it may last till almost about 1.5 years to 2 years, is a phase where the previously formed insulin is being used up, and during this period the insulin requirement of the child goes drastically low. That child, even a child weighing about 30 kilos, 40 kilos, might require only as much as 1 unit per day. So this is the period which you should address before starting treatment itself. They should be told that during this period that child's requirement may go down drastically, And you should not stop measuring blood sugar levels or managing or follow up during this period, because most of the time such children end up in decay later on because they feel that their diabetes has been cured, or possibly during this phase of denial they fall prey to a lot of alternative therapies, and that is when they feel that that has worked and possibly their diabetes has been completely cured. So you have to address it before sending the child home. And a big no to all the fraud alternative therapies that are available or being endorsed around. Now, before the child goes home, the child has to be taught, or the family has to be taught or given basic diabetes education. Hypoglycemia management is, I think, the most important thing to be taught before the child can go home, or even before the child can be sent or discharged. And very importantly, every child's needs are different, every child's body is different, every child's socio-cultural strata is different, their finances and economic constraints are different. So treatment has to be individualized for each child. It cannot be one size fits all approach. You have to individualize it to the child's requirements. What should be our goals of care? First and foremost, the child should not be made to get treatment only to survive. The child, our aim should be to attain a high quality of life for the child. We have to ensure normal growth and development during this period. The child has to be made or enabled to have good psychosocial adaptation. And it is our duty as pediatricians and primary clinicians to detect early all the comorbidities that are associated with type 1 diabetes. And of course, the main aim should be to avoid complications, the acute complication being diabetic ketoacidosis, but the long or chronic complications being all the microvascular and microvascular complications. So what are the components of care? The 4 pillars of management of type 1 diabetes are insulin, blood glucose monitoring, prudent meal planning or medical nutrition therapy, and physical activity. But at the center of it all, you should be providing adequate and comprehensive education to the family and the caregivers of the child living with type 1 diabetes. Now, it is a multi-layered approach. So we have to back this up with follow-up, regular follow-up and investigations. Emergency management should be made accessible to the child. Then complication screening is a big part of management and ambulatory care of type 1 diabetes. And very importantly, and last but not the least, the child should be immediately connected to a type 1 diabetes support group. This will help the child in coping and the family in coping with the initial stress and getting used to and being compliant to the treatment. So what is needed for this management? It's a multidisciplinary team. At the center of it all is the young person who's living with type 1 diabetes and family. But then the pediatrician, who is the primary point of contact for children with type 1 diabetes, should be at the forefront of this team. Then we have trained additional caregivers, pediatric diabetes medical providers and pediatric endocrinologists. Diabetes educators and nurse specialists or dietitians should be made available to them immediately. Now, in this era, we've got a lot of advancements in the management of type 1 diabetes. So they should be told and at least introduced to the advanced diabetes technology that is available, and it should be made accessible to them. Psychologist is an important part of the team, and they help children because it is undermined, and this particular aspect of a child living with type 1 diabetes, there's an enormous level of stress. We come across many teenagers who try to skip insulin on their own. They try to commit suicide. So I think a psychologist should be involved in the care. And very importantly, daycare and school support from the nurses, teachers, and coaches should be sought. So I think when, as a pediatrician, we should write a letter to the for the family, to the principal, emphasizing on the child's need to take insulin regularly, which may require to be given even during the school hours. The child and the hypoglycemia symptoms should be made available and written down on the letter to inform the school authorities and the teacher as to when they should act. And emergency care contact should be immediately provided to them. This is, I think, very important because children spend almost half the day in school nowadays, and I think this is something that if their school management is hampered, I think we are not going to succeed in management of type 1 diabetes. So very importantly, usually these children visit their pediatric endocrinologist once in 3 months. But between this period, we have to maintain an inter-visit communication channel, which is extremely important. So what can we do for that? We can provide them with a 24/7 helpline number where they can call in anytime and ask for queries and avoid emergencies. We can form WhatsApp groups for minute management of type 1 diabetes, wherein we can include diabetic nurses, we can include diabetic educators and the doctor at care, and they can help with their management. Then during this period, it is also important to have online meets. These meets can be educational, informative. These meets can be just meet and greets or just simple discussion about type 1 diabetes and various aspects. And also we should have physical meets. So support group meetings are an important part of management of type 1 diabetes. Just like Dr. Enu Borakar ma'am previously showed us the images of, they go trekking, they can have camps which are just play oriented. They can have camps which are education oriented. And during this, they develop a sense of belonging and they feel that they are a part of a bigger community and they're not alone. So I think this is something that is extremely important and usually not discussed as a part of medical therapy to type 1 diabetes. So then coming to the most important therapeutic modality now, insulin therapy. Now, I must reiterate that insulin therapy should not be given only to survive, but it should match and it should be given in such a way that the child will be able to thrive well. So what are the different types of insulin? We have long-acting insulins, which are available in the form of glargine, which acts for about 24 hours. Now, if you look at the graph on the right, insulin glargine has a peakless profile, so it doesn't peak and it acts for about 24 hours. So I think it is the most ideal basal therapy to give. Detamir is available, which acts for only about 12 to 14 hours. This needs to be given twice a day. And usually it is not desirable to use it in the management of type 1 diabetes. Short-acting insulins, which is basically regular acting insulin. Now this duration of action of this insulin is about 6 to 8 hours. Now the drawback with this is it has to be given 30 minutes prior to the meals. Secondly, if you look at the graph, it has a tail effect. So towards the end of its pharmacokinetic profile, it tends to be present in the circulation and sometimes children experience hypoglycemia associated with it. Then we have rapid acting insulins, which are available as Lispro, Aspart and Glulisine compounds, which act for about 4 to 5 hours. Their duration of their peak onset is at about 2 to 3 hours and their onset starts within 10 to 15 minutes. So this can be given about 15 minutes prior to meals. And this is, I think, currently one of the most desired therapies for children living with type 1 diabetes. Now, with times, we have developed better insulins. So we have got ultra long acting insulins, which are Degludec and Glargine U300. Now, these have an action profile which lasts for almost about 36 to 40 hours. Having said that, it does not mean that they should be given after 36 hours or 40 hours. They have to be given once a day at the same time every day. But they have a peakless profile and they provide a better glycemic control. But again, they come with an added cost. And then we have ultra rapid acting insulin. So children who are young, possibly below the age of 5 years, who are frequent eaters or who are fuzzy eaters, we don't know if that child is going to take insulin and then eat regularly. There we can use compounds like Fiasp or Lumjev. Now, these compounds are beneficial in such a way that they can be given only about 2 to 5 minutes prior to meals. Sometimes, if the child or if we are not sure if the child is going to eat, we can give this insulin postprandially immediately as well in some cases, but it is advised that it has to be given before the meal. So what are the insulin regimens that should be given? Now, the most common and the most ideal insulin regimen is basal bolus therapy, which requires about 4 to 5 injections per day. So what is constant is a basal dose. So one basal dose which has to be given at night or in the morning, depends on the decision of the clinician. It is preferred, or if you're giving glargine, it is preferred that you give it at night. If you're giving Degludec, it is preferred that you give it in the morning. Now, this has to be supplemented with 3 to 4 prandial bolus doses. What is basal dose going to take care of? It is going to take care of the fasting blood sugar levels and the blood sugar levels which are not related to meals. And then you have to give 3 to 4 prandial doses based on for 3 major meals or 3 to 4 major meals. And these will cover only the glycemic excursions related to those meals, particular meals. Then we can have a split mix regimen, which involves about 2 to 3 injections per day. Now, this primarily involves using mixed insulins or mixing of insulins or pre-mixed insulins. This can be given pre-breakfast and pre-dinner. if you're giving a 3 injection protocol, then you can give NPH plus short acting pre-breakfast and pre-dinner, and then 1 additional short acting insulin before lunch. And then the latest and the most ideal regimen is continuous subcutaneous insulin infusion, which can be given using insulin pumps. So having said that, I think we have to consider 3 E's before starting the child on any of these regimens. First, look at the child's eating pattern. How many times the child eats? If the child eats almost every 3 to 4 hourly, giving a basal bolus regimen may be problematic if the child or the family is not going to be compliant with it. Then education of the family and how the family is going to be able to carry out the instructions that are given, and of course the expenditure capacity of the family. All of these taken together in consideration will help us individualize treatment for that particular child. And to sum it up, basal bolus therapy or regimen for all as much as possible. Only in a few rare cases may premix insulins be used, but it is a big compromise on their care. And insulin pumps for all those who can afford. This is the message that I want to send. At least when the child is being told and counseled about type 1 diabetes, you must mention the latest advancements that are available and tell them about what is the current best possible treatment that modality that is available. So the dialogue for insulin pump should start right at diagnosis. They may or they may not use it immediately, but in future they may be able to use it. Now coming to insulin delivery devices. So we have syringes available and insulin pens. Now syringes usually come in 2 strengths, and this is something there where many clinicians I think overlook many a times. So what happens is there are 2 syringes. One is orange insulin syringe which contains a calibration of 100, and the other is a red insulin syringe which contains a calibration of 40. So it is 40 units per ml, and the orange one is 100 units per ml. So on every visit, if a child is using insulin syringes, you must check and emphasize that an orange syringe or a 100 unit syringe should be used for a 100 unit per ml formulation of insulin, and a 40 unit syringe, or that is the red one, should be used for a 40 unit formulation of an insulin. And then we have now these insulin syringes are usually cheap, but they come with needles which are 8 mm or 5 mm. So basically they are associated with some amount of pain. So the pricks are painful. It is less feasible or less convenient for the child to carry them everywhere, because they have to carry the vials separately, they have to carry the insulin syringes separately. Then what we have is insulin pens. Now they are available as disposable pens or refillable pens. And the needles are now ultra thin. 4 mm needles, about 32 G are available, 5 mm needles are available. Now these are ultra thin, almost penless pricks. These are very convenient, easily portable, can be carried everywhere, and they sometimes come with some added cost. But I think in today's time, the costs have come down significantly. Usually the insulin cartridges which are used in insulin pens cost only about 100 or 200 rupees extra or more than what it costs for insulin vials. Then we have some devices which were introduced for children with extreme needle phobia. So we have iPorts, which involves basically a port on the site, and insulin is to be injected in that port, and it gets dissociated slowly into the skin. And we have insulin injectors, which are basically painless or prickless insulins. However, iPorts have slowly been phased out. In injectors, we have observed over the last couple of years and over the last decades that the absorption is very variable. So the action being very variable, I think it is not extremely desirable to use insulin injectors. And having said that, the cost of both these are extremely high. So I think these are not something that should be discussed in countries who are developing or low socioeconomic strata. So in insulin delivery devices, we've undergone a paradigm transformation. Now, this was the first insulin pen which was introduced by Novo. Then this is Dr. Arnold Kardish with the first insulin pump. Imagine the size of the pump and carrying it everywhere. Then we came up with a pump which is only a size of the iPod, and then it is connected to an insulin port which has to be changed almost every 2 to 3 days. So this saves the pricks from almost 180 pricks a month to only about 10 pricks a month. So these are the different, this is the evolution that we have achieved in the last decade of insulin delivery. So coming to the most interesting aspect of type 1 diabetes management, insulin delivery devices. It consists of an insulin infusion set or a port which bathes in the interstitial area, and the cannula is inside, and it is able to provide or give continuous supply of insulin. Now, what are the most important points about insulin pumps? It provides the most physiological delivery. Now, it can provide or it can deliver doses as low as 0.0 to 5 units. And again, we can give various basal doses for various times at a predetermined rate. So say a child is having dawn phenomena, or around 4 o'clock he starts spiking sugars. We can increase the delivery rate of basal insulin between 4 to 8 a.m. If the child has hypoglycemias towards 1 a.m. in the night, we can decrease that insulin delivery rate during that time. So it is that physiological. It is extremely expensive at this moment, but through some schemes and some NGOs, I think the accessibility to such devices is getting better and better with the day. It allows for greater flexibility, and the injection site has to be changed only every 2 to 3 days, as compared to almost 120 to 180 pricks for a child with type 1 diabetes during the month. Now, I always tell usually the families that I cater to, I tell them insulin pumps have to be earned. Basically, they have to undergo comprehensive training and support initially to understand the complexities of managing insulin pump, and then only should they be given the responsibility of handling an insulin pump. Because if they do not understand the concept of carb counting, if they do not understand the intricacies related to management with insulin pumps, they may end up in bad decay. If there's a tube kinking or there's a pump failure, they are not able to recognize it. It may be fatal for them. Having said that, insulin pumps provide a better quality of care. So that now this is the epitome of care for children currently with type 1 diabetes. Now there are newer pumps which integrate with the continuous glucose monitoring system. So they're integrated to it. They take information continuously from the glucose monitor, and they also act on their own to provide insulin or to suspend insulin supply during low glucose states, or when the glucose trends are showing low, or when they are going to go down, it immediately suspends it. So again, they are also available with cloud-based surveillance. So the caregiver or the clinician can also access this data day to day. Now, this is the most important part of management of type 1 diabetes, because when a child visits their primary treating pediatrician, always we should re-emphasize on the need for good and proper technique of insulin delivery. And we should always check how they're delivering or using or taking insulin injections. So it has to be injected subcutaneously, and a good pinch up of the skin is to be done. Now, what this will help is it will avoid the muscle layer, and it will help us inject only in the subcutaneous layer. And it has to be injected at a 90-degree angle. Now, we have to hold the needle in place for 8 to 10 seconds. So you have to ask the child to count till 8 or 10 before removing the needle. Now, after that, let go of the skin and remove the needle. Usually, there may be some blood drop or insulin drop at the site after removing the needle. So don't worry about it. Just press on that area for about 10 seconds and leave it. That is enough, and that is a good technique to manage. Now, this is only half information. You must also tell them the sites of insulin delivery. So if you look at this, abdomen has the quickest absorption of insulin, and then after that is a lateral aspect of arm, which has an intermediate absorption, then front of the thigh or lateral thigh, which is slow, and the last or the slowest absorption is in the lateral upper quadrants of buttocks. So my experience and my teachings teach us that we can give basal bolus or basal dose in the buttocks or thighs, where it can be slowly absorbed and act for a longer time, and we can give the prandial doses in abdomen and the thigh. Usually in children below the age of 8 years or even 10 years, we avoid giving in the lateral aspect of arm, because they have a very less pad of fat over there, and then they might end up injecting it in the muscle layer. How do you rotate the site? So again, when you're giving it there, if you continue to give it at the same site, you may develop a lump on the skin, which is lipohypertrophy. So again, this is a graph which just shows that you have to keep on rotating insulin administration sites. And again, what is to be very importantly remembered is that when you're switching or moving on to the next site, it has to be at least a 1 finger width beyond the previous site. Secondly, it is, I think, a good idea to give a particular prandial dose at a particular site of every day. So say a breakfast dose, if you're giving in the thigh, every day you should give a breakfast dose in the thigh by rotating sites. Lunch dose, if you're giving in the abdomen, continue giving it in the abdomen, but rotate sites in the abdomen. Similarly, for the basal and the other dinner doses. So I think that is a good practice to follow. Now, most importantly, how do you initiate insulin? First is you have to calculate the total daily dose required for the child. Usually children just coming out of diabetic ketoacidosis have insulin requirements which are high, which almost amount to 1.5 to twice the units per kg per day. Then for a prepubertal child who is not in DK, he may be started on insulin at 0.8 to 1 unit per kg per day. And pubertal child, usually because of the other pubertal hormones, there's a surge in and there are multiple glycemic excursions. So there is an increased demand for insulin, and there we have to slightly increase the dose to 1 to 1.2 units per kg per day. So how do you calculate the basal dose out of it? So say for a child who's about 30 kilos, who's not in DK, we start him at about 1 unit per kg per day. So the total daily dose comes out to be 30 units. Now the basal dose has to be divided and into given as 30 to 45% of the total daily dose. So for him, usually it may amount somewhere around 12 units or 11 units. And how do you calculate the prandial dose or the bolus? The conventional approach is to divide the remaining dose by the number of major meals that the child continues to have. So if the child has, say, breakfast, lunch, and dinner, you divide the remaining dose. So if you subtract 12 from 30, you divide 18 by 3, that becomes the bolus for each prandial meal each meal that the child consumes. Now, how are these boluses titrated? Usually, you may titrate it based on a BSL scale that is provided by the clinician. So, based on the child's glycemic variability and sensitivity, we may provide a scale which says between 100 to 200, you may give the stipulated dose. 200 to 300, you may increase the dose by 1 unit or 2 unit depending on the child's insulin sensitivity, and so on and so forth. So that is one way of managing it. The other way is by managing or explaining to them carb exchanges. So by telling them, say the child is going to consume or anticipated to have one more chapati during that meal, then one chapati would come to about 20 to 25 grams of carbohydrate. So you may tell them that if there is this particular carb exchange and if the child is going to have that, then you may increase the dose by 1 unit for this particular carb. Then comes a more accurate way of managing and calculating the prandial dose, which is by calculating and educating the family about insulin sensitivity factor and insulin carb ratio. So what is insulin sensitivity factor? It is the amount of sugars that can be reduced by giving 1 unit of insulin for that child. And what is insulin carb ratio? It is the amount of carbs that 1 unit of insulin will cover for that child. So for children on rapid acting analogs, we use a formula of 1800 by total daily dose. For children on short acting insulin, we use a formula of 1500 divided by total daily doses. Now for insulin carb ratio, 450 by total daily dose or 500 by total daily dose is the usual common formula that is used. For children who require less than 10 units per day or children who are extremely small, for them, we use a formula of 300 divided by total daily dose. So let's take an example. This is how the prandial dose calculation is done. Let's say you set a target of 120 for that child post meal or postprandially. So the BSL that child has, subtract 120 from it and divide it by the insulin sensitivity factor, and also add the insulin that is going to be required for the meal that the child is going to have by calculating carbs in grams divided by insulin carb ratio. So for a child who's 10-year-old weighing 30 kgs with a pre-meal sugar of 240 and the anticipated carb count of 60 grams, the total daily dose by calculating 1 unit per kg per day comes to about 30 units. So the insulin sensitivity factor for him is 1800 divided by 30, that is 60, and insulin carb ratio is about 15. So for the calculation would be something like this. So 240 minus 120, that is 120 divided by 60. So that comes to about 2 units, and 60 grams of carbs divided by the insulin carb ratio, that is 15, that comes to about 4 units. So the child may require 6 units for that particular meal based on that particular pre-meal sugar and carb count. So for this, it is essentially important that the family learns carb counting. If they're not aware or if they're not good at managing or learning carb counting, I think this can be fatal too. And all our efforts should be aimed at comprehensively teaching them the essential basics of carb counting. There are multiple apps which are available now which can easily count the carbs for you, which are Indianized. So all the Indian recipes and food items are placed on there, and you can simply put in that data, and you can quickly get a carb count. Very importantly, storage and transport. Now, storing insulin is an important aspect, and always when the child visits your clinic, always ask them how they're storing and where they're storing. So all the unopened vials and pens should be kept in fridge, but they should not be kept in a chiller tray. They should not be kept in freezers. They should not be kept on the door sides. They should ideally be kept in the middle compartment. Now, it is told or mentioned in the insulin leaflet, the injection leaflets, that they can keep open pens at room temperature. But by room temperature, they usually mean 25 to 30 degrees Celsius. In India, it is quite uncommon to have this temperature, and usually we have temperatures which are above 35 or 40. So again, it is a good idea to store open pens and vials also in the fridge. Now, what about transporting? When a child is visiting your clinic, say it takes about 4 to 5 hours to get consultation. During this period, again, that insulin vials or the pen may get damaged. So again, and this particular image is for the conditions where the children are living in extremely resource limited settings, do not have access to a fridge. So this is, I think, an adaptation from Udan Foundation itself. Dr. Archana Sarda has very graciously given out images of the particular technique that they have been using. So you use two pots, a bigger pot with sand inside and keep a smaller pot inside with insulin inside it. That usually helps in very extremely resource limited settings. How do you transport insulin? There are available carry cases like Frio bags or insulated devices. If you do not have access to those, or sometimes they're expensive, you may form or DIY your own insulin carriers by using thermos flasks and keep ice packs in it or some ice in it with insulin packed in a bubble wrap inside it so that it doesn't get wet. Now, I would like to reiterate that when children are traveling or are anticipated to travel by air, it is important to tell them that they should not keep insulin in the check-in luggage because it is amenable to various temperature changes. And again, it can damage the stability of the insulin. So we've seen that glucose monitoring over years, when it started or back in 1500 BC, we used to diagnose a diabetic by the gathering of ants over there. Then we started or developed bedside reagent strips, which were done. Then the first glucometer was formed or developed in 1968. Fast forward to this day, we have very portable, very simple, and very small glucometers which are available, which divide and which give a very good glycemic profile and are very accurate. So what about monitoring? I think it is the most important message that I would like to give. A cost of not testing is more than cost of testing. So again, when these glucose strips are usually costly, expensive, and people find it difficult to continue with regular multiple glucose checks every day. But again, when a child doesn't measure, it's like aiming or shooting an arrow in the dark. They don't know what they're planning and what doses they're going to give. So again, they have to be told that if they do not test, they may end up with some acute complication or some long-term complication which might cost them more. Now, blood glucose levels are not just an effect of what the child eats. They're also dependent on the insulin regimen or the doses that you give. Very importantly, they are affected by the pattern of eating. So if a child is eating frequently, they're going to be affected. And again, monitoring becomes a very essential part here. And they're affected also by the activity or illnesses or intercurrent illnesses that the child may experience during the course of his type 1 diabetes management. So what are the patterns of testing which are recommended? The most recommended and ideal pattern of testing is by measuring pre and post meal sugars. So that becomes 3 pre-meal sugars, 3 post-meal sugars, that is 6 sugars, and 1 bedtime sugar, that is 7 tests per day. The second most or the Second desirable pattern of testing would be by doing at least pre-meal sugars and bedtime sugar. That amounts about 4 tests per day. Now, in resource limited settings or with financial constraints, this is a still acceptable pattern of testing. Fasting sugars and pre and post prandial sugars for only one selected meal a week. So that becomes only about 3 tests per day. That can be done in cases where where the family is associated with very poor compliance or usually have very poor access to insulin strips. This should never be done. Only measuring sugars during hypoglycemic symptoms is not an ideal treatment and should be discouraged every time the child visits. How do you measure sugars? Of course, you measure it with the blood glucometer, but it is important to understand that you have to skip these 2 fingers, the thumb and the index finger, and usually use these other 3 fingers for management, because regular measuring may cause some pain to the child and possibly affect his school activities or writing and other fine-tuning activities. So where do you measure blood sugar levels? You measure usually in the side of the pulp of the finger and not the middle and the top part of the finger. So usually there are most of the nerve endings are present inside at the middle of the finger and the tip of the finger. So avoid those sides and measure usually on the sides. Again, we have families who come and they usually measure sugars in their toes, in their calf muscles. So I think this should be highly discouraged. Now, when you monitor sugar, it is not useful unless it is logged and written down. So monitoring pattern has to be individualized for the accessibility of the strips. But importantly, we have to learn and teach the family to interpret every sugar and then also to take action. And how do you interpret this basal sugar or the BSL monitoring? The fasting glucose is affected by the basal dose. So it indicates the basal dose adequacy. Post-meal sugars are usually secondary to prandial meal doses. And pre-lunch sugars are affected by the breakfast dose. And if there are any snacks which are consumed between the breakfast and lunch. Pre-supper sugars again are dependent on the lunch dose, but also additionally on the basal dose. And if the child has consumed any mid-afternoon snacks. And at all levels, you must always check if the child has consumed snacks between the meals or between 2 major meals, and also what kind of exercise the child has undergone. The next modality of monitoring is HbA1c, which has to be done quarterly because it is glycated hemoglobin. So the RBC lifespan is usually about 90 to 120 days. So it indicates an average blood sugar over the last 90 days, that is 3 months. Now, it has to be done on standardized assays. And usually it is affected by conditions with low RBC lifespan, so hemoglobinopathies, iron deficiencies, or conditions with dehydration with high hematocrit or low. So now, having said that, and even if we've gone and evolved a lot in monitoring of blood glucose levels and glycemic profiles, HbA1c still to date remains one of the most robust indicators of overall control of type 1 diabetes. So this is from the DCCT study, which shows lower HbA1c is associated with decreased risk of long-term microvascular complications. Now, what are the caveats that we usually face with HbA1c? If you look at these graph, the green indicates the glucose values which are in range between 70 to 180. The pink indicates the values which are low, that is hypoglycemia. And the yellow area indicates the values which are high or above 180. So the first candidate has sugars which are spiking and then going extremely down. So he has hypos and hypers regularly. The second child has some hypos, mild excursions of glucose, but not always in the green zone. And the third child is always in the green zone or has sugars always in the target range. So even if you look at them, the time in range of the blood glucose in the normal range is 100% for the third child, is only 63% for the second, and only 18% for the first child. However, all of these child surprisingly have a good HbA1c because it is just an average of the overall sugar or glycemic profile over the last 3 months. So there are caveats associated with HbA1c and calling it the most robust indicator. So it misses the most important intraday glycemic variability. And for that, we've moved on to better indicators, which are continuous glucose monitoring systems. Now, this is just an example of the ambulatory glucose profile. If you look at the top right corner, you can see the target range. So these are the new metrics which we measure and which we use for checking the glycemic profile of the child. So the green zone is the target range or the time in range, which has to be higher or more than 70%. The red zone has to be less than 5% and the yellow zone has to be less than 25%. If you look at the graphs below, this particular system helps us see graphs of daily activities or daily glucose variabilities, and also a graph over the last 7 days or 14 days averaged out. So it adds a great deal of flexibility and lifestyle, and it offers insights on various effects of foods and activities. So CGMS, again, I must reiterate, is a must wherever possible. And it is my personal recommendation that it should be used at the start of diagnosis. It is recommended by ISPAD as well. And also, if the resources do not permit, at least once in 3 months for the child and the family to understand what affects the blood glucose levels and to understand the glucose trends better. So what are the glycemic targets? We want to achieve HbA1c between 6 and 7 as much as possible. Then there are some erroneous and caveats when we are looking at HbA1cs. So in cases of hemoglobinopathies or children requiring frequent transfusions, HbA1c is not reliable. And in that case, there are some alternatives to it, like fructosamine levels, which can be done and which indicate the glycemic profile over the last 4 weeks. Then self-monitoring of blood glucose levels. What are the targets that we should advocate and try to achieve? Pre-meal sugar should be between 70 to 130. Post-meals should be between 90 to 180. And bedtime sugar should ideally be between 80 to 140. To simplify for everybody, I think all sugars of any child living with type 1 diabetes should be between 70 to 180. That still will help us achieve a reasonable glycemic control. And when you're using a continuous glucose monitoring system, as I mentioned earlier, the time in range should be above 70%. Time above range should be less than 25%. And the time below range for sugars, which is less than 70, should be below 5%. And hypoglycemias, which are fatal, which is less than 54, should be less than 1%. Coming to the third pillar of management, that is the medical nutrition therapy. So I would like to tell and again emphasize on this fact that there is no such thing as a diabetic diet. So do not use these terms, because usually when we start or tell them that it's a diabetic diet, they get scared. It's a devastating news for the family that they are not going to be able to eat or going to miss a lot of important things going ahead. And it is important that we do not make any blanket statements. So do not make statements like avoid rice completely, avoid chapati completely. They can eat everything that a normal child can eat, and every child should be eating a balanced, healthy diet. That is what a child living with type 1 diabetes also needs. Now we can individualize the diet or medical nutrition therapy to the child's specific delivery needs. So a pubertal child may require a little more on the caloric side. A child who's slightly lesser in age may require lesser calories. So age-based calorie requirement should be taken into consideration. Always the focus should be on healthy eating, and we should avoid advocating or recommending very low or extremely low carb diets. Now, it is a good idea to add protein and fiber to every meal. So advise them and tell them that before or at the start of every meal, you should have a portion of salad and add a portion of protein to it. Why this helps is it blunts the glycemic excursions. It improves the feeling of satiety in the child and keeps the child fuller for a longer time, avoiding frequent snacking. And these children are, of course, always allowed to have occasional indulgence in high glycemic index foods also. So they should be able to avoid, they should be able to, attend parties or say go to a birthday party or, go to any other function and eat flexibly. So now the treatment approach has over the years changed. Initially, we used to give for food according to the insulin needs of the child. Now we've moved on to a more flexible approach where we can or we should empower the children or family to give insulin based on the food that the child is going to eat. And this is a particular Indian thali which shows a mixture of everything: good amount of salads, good amount of fibers, good amount of proteins, good fats, and along with that carbs and the good amount of probiotics in it. So what are the nutritional recommendations? The carbohydrates should be about 40 to 50% of the energy, total energy required. Sucrose intake should be refrained or should be restricted to less than 10%. Fats should be about 30 to 40% of energy. However, the saturated fat should be less than 10%. And protein should be about 15 to 25% of the total energy requirements. Now, again, we often get questions from the family if the child can eat sugar-free biscuits or sugar-free products. So sugar-free does not mean carb-free. It still contains a large amount of carbs. It still contains a large amount of fats. So beware, there are certain recommendations given out by ISPAD on the recommended amount of non-nutritive sweeteners which are commonly used. So sucralose, saccharin, aspartame, stevia glycosides, and monk fruit extracts. However, it should be told and informed to the family that these have to be used only as the over-the-top dispensers, only in certain and in moderation. They cannot be or they should not be used liberally to produce sweet delicacies. And the most important, the last pillar of diabetes management is exercise. It has to be recommended for all. A type 1 diabetes, a child who's living with type 1 diabetes should be able and should be recommended to exercise daily for at least for 30 to 45 minutes of intense or vigorous exercise. Now, it obviously helps control the weight, but also helps in glycemia and to curtail the stress. Now, aerobic exercises are usually associated with delayed hypoglycemia, which can happen almost as later as 12 to 14 hours post the exercise. And anaerobic exercise can also are usually associated with immediate hyperglycemias. So how do you manage this? If the blood sugar level, so you basically measure sugars before and post exercises also additionally. If the sugars are less than 90, you correct it and bring it above 90 by giving a 0.3 to 0.5 gram per kg of quick acting carbs, and then you send the child to play. If the BSLs are between 90 to 120, you give about 0.8 to 1 gram of so slow acting carbohydrates or complex carbs, which for each hour of the exercise. So after an hour, if the child is going to exercise for about 2 to 3 hours, you call the child back and give them a small snack again. Between 120 to 250, the child can start exercises, but above 250, always check ketones. If they're present, you should avoid exercise that day. If they're negative, then correction doses may be given before sending the child for exercise. Now, hypoglycemia management, again, the most important message is that it has to be taught before discharging the child. Now, what are the common causes? Usually a dose meal mismatch, exercise which is not complemented or supplemented by insulin doses or BSL monitoring, and sick days. What are the symptoms? Usually drowsiness, tremors, sweating, convulsions, a multitude of symptoms can be seen. And if the child continues to have repeated episodes of hypoglycemia, they may develop something called as hypoglycemia unawareness syndrome, where even at sugars as low as 30, they may not exhibit symptoms of hypoglycemia, which may become eventually fatal. So how do you define hypoglycemia? Any sugars which are less than 70 is hypoglycemia and has to be corrected. Any sugar which is less than 54 is fatal and requires immediate correction. And a very simple rule of 15, 15, 15 has to be remembered. You give 15 grams or 0.3 gram per kg of quick acting carbohydrates, usually a sugar, powdered sugar or glucon-D in half a glass of water. Then wait for 15 minutes and recheck the blood glucose levels. After that, this has to be followed by a 15-gram carb snacks. If you leave it, the sugars or the quick acting sugars that you've given are going to vanish from the body in the next 40 to 50 minutes, and the child may experience hypoglycemia again. So you follow it up with a 15-gram carb snack, which can be a bread slice, a fruit, or a small roti with omelette. And if the hypoglycemia is persistent, then the child may be equipped or may be given a glucagon pre-filled syringe, which can be given as 0.5 mg for children below 12 years and 1 mg for children above the age of 12 years. Last, second slide, I think, the sick day management. So during sick days is when the child is most vulnerable to developing diabetic ketoacidosis. So remember this mnemonic SICK, sugars have to be checked 4 hourly during sick days. Do not omit or do not stop insulin because the child is not consuming. Sick days are usually a period or a phase of ketosis. and that is when insulin is, in fact, there are increased needs of insulin during this period. Do not skip meals as well. So give carbohydrates or give meals and in supervised manner, and check ketones regularly. So how do you check ketones? As ma'am has very beautifully described in the previous slide also, you can check urine ketones. If they are large, then the child requires hospitalization. If they're small to moderate, probably the child can be managed with multiple doses of correction doses and regular blood glucose monitoring and hydration. Now there are point of care blood ketone meters which are available, and I think every PICU should be equipped with one of those. Now, what it helps it is it immediately picks up the onset of ketosis. If the values are more than 3, the child should be immediately hospitalized. If they are more than 0.6 but less than 3, those are abnormal but can be managed under supervision or on OPD basis with constant supervision. Now, again, as ma'am expressed in the previous slide, urine sugars should not be used to look for resolution of diabetic ketoacidosis or ketosis. It should be the blood ketone meters which contain beta hydroxybutyrate. And the important messages are never to omit insulin. Usually febrile sick days are associated with hyperglycemia, so they require correction doses and frequent monitoring. Diarrheal sick days are usually associated with hypoglycemias, and in such cases sometimes we have to make sure that we do not omit the basal insulin at all. The prandial insulin may be given according to the blood sugar levels and the oral intake that child is anticipated to have. Now, it is extremely important to maintain hydration during this period. And if the child has an extremely poor oral intake and is not accepting fluids as well, I think BSLs, if they are less than 180, we can give sugar containing fluids like ORS or less sweet lassi. And if the BSLs are above 180, we should give them follow-up visits. Every visit you should check the anthropometry, pubertal assessment. Blood pressures on every visit must be done at least twice in a year, and foot examinations for any onset or changes of peripheral neuropathy or diabetic neuropathy. Now, most importantly, you should always inspect the injection sites on every visit. These are just some examples where the child has extreme lipohypertrophy on both sides of the abdomen, and on the other image you can see the discoloration of the skin because of constant repeated insulin injection at the same area. How do you screen for complications? For nephropathy and for retinopathy and hyperlipidemia, you start at least 2 to 5 years post-diagnosis, or if the child is above 11 years of age, then you do it at diagnosis and then you do it annually. How do you check for nephropathy? You do urine microalbumin to creatinine ratio. For retinopathy, fundus examination. And for hyperlipidemias, you check the fasting blood lipid levels. And again, type 1 diabetes is an autoimmune condition, so it can or be associated with other autoimmune conditions like hypothyroidism. So it is advisable to do thyroid profile at diagnosis itself and antibodies if resources permit, and then it has to be repeated annually because it may develop at any point of time. Celiac disease, should the total IgA levels and PTG-IgA antibodies should be checked at diagnosis and then whenever the child is symptomatic. Usually both these conditions, if they appear later, they may appear with symptoms or the child may experience unexpected lows or hypoglycemia. So during this period, again, you should suspect such cases. Then there are rarely some other comorbidities like adrenal insufficiencies which may appear and pernicious anemia. So again, these children have to be connected to peer support groups. Multiple group meetings have to be encouraged. And what it helps it helps in motivation from others' lived experiences. It helps them accept or get accepted psychologically and socially. And all the T1D leaders or the children who are type 1s who have been living with it for years make great leaders and make great motivating educators. So all of them should be involved in their care. Now, this is just a slide on how we have fared so far and where we are possibly heading. In terms of glucose monitoring, we are possibly moving towards wearable devices which can monitor glucose without pricking or without which are non-invasive. And for treatment parts, we are also moving towards hybrid closed loop systems, which are an extension of the insulin pump, or stem cell therapy. And here again, those stem cells usually get destroyed in circulation. So we are now developing systems which can help in encapsulation of the particular stem cells, which can reach the target organs safely. So the take home message is type 1 diabetes and type 2 diabetes are not the same. Reiterate, tell them, write it on their file immediately and before discharge. Early detection is associated with better outcomes. Basal bolus regimen is the only ideal choice. Insulin dose should be given for the carbs that is eaten and not the other way around. This helps in better flexibility. And continuous glucose monitoring system and insulin pumps for anybody and everybody who can afford. And always educate and empower the family living with type 1 diabetes so that they can manage diabetes on their own. Thank you. This is just a slide on showing equity versus equality, where we do not aim to provide equality to children with diabetes. We want to provide equity, where they should be able to live normally and do everything that a child does. And on the right, you can see Alexander Zverev, who's a a lawn tennis player who's living with type 1 diabetes and doing extremely well. So thank you for your patient hearing.
Yes, Dr. Ajinkya Patil, for a very lovely, very illustrious talk. And I think it was very important highlighting the need of a multidisciplinary approach to pediatric diabetes. Very illustrative talk and basically extremely practical points, making a complex topic relatively simple. And availability of newer sensing devices as well as treatment modalities and pumps gives us a hope for a better future for these little children. Now, going ahead with the questions which I see in the chat box, a quick one is, are the cutoff levels for adolescents in sugar different from the childhood diabetic cutoffs?
So in terms of HbA1cs, usually in younger children, we may accept HbA1cs till 7.5, but the recommended cutoffs remain the same for all the age groups. However, for blood glucose levels or blood glucose targets as well, we may sometimes accept sugars till 200 or 220 for younger children, so as to not keep a very tight control, and which may subject them to increased risk of hypoglycemias. So I think that from a practical point of view, that can be done.
Okay. And is there an Indian app for carb counting or carb calculation?
There are apps, usually, I mean, some of them from my experiences or from the T1D care groups. Healthify Me is something that has been used reliably. There are multiple other apps as well.
Yeah, so if you could be kind enough to put it up in the chat box, it will serve.
Okay.
And what is the price of a blood ketone monitor, which you said is very necessary in all ICUs?
So the blood ketone monitor many a times is provided free of cost by the company, but the blood ketone strip usually costs about 175 to 200 rupees per strip. But if you want to buy the blood ketone meter, I think it comes somewhere around 1,000-1,500 rupees.
Okay. And our last question is, we always give insulin in subcute form. Why is it not given intramuscular? Because of erratic absorption or faster absorption, or what is the reason?
So basically, insulin analogs or the short-acting insulins or basal insulins, they are basically hexamers or different form monomer. I mean, they have to be converted into monomers when they get dissociated into the blood circulation. If you are giving it in the muscle, they're going to get dissociated completely immediately. So their action profile or the pharmacokinetic profile may not be as what is desired or what is predetermined for them. So.
Okay, so I see I've asked all the questions posted in the chat box. So I think I'll just give a vote of thanks as we come to the concluding part of today's session. So a big thank you to Dr. Pakmode sir, who's President MahaIP, and Dr. Amol Pawar, who's Secretary MahaIP, for supporting us in the committee of MahaIP to carry such good programs on Thursdays. Dr. Jayesh Shivalkar, madam, who has been instrumental and monumental to take it right ahead on each of the Thursday thrills. It is quite a tall task doing it for the year round. So a big round of applause to her. And excellent speakers today, Dr. Renu Borarkar gave us very good, valuable insights into DKA management, and Dr. Ajinkya Patil, whose talk was, very, very to the point and practical. So and a big thank you to Pallavi, who's the backbone of conducting and giving us techno support for conducting these sessions on Thursdays. So, and lastly, I would like to thank MahaIP Women's Committee for giving me a chance to moderate this session. It was lovely interacting with all of you, and we had a robust audience. So thank you so much, all of you, and have a good night.